All right. Good afternoon, everybody. Again, this is Nirav Shah from the CDC. I'd like to take a moment to thank everybody for hopping on this afternoon. We very much appreciate your time and your interest in joining us to hear the latest with respect to COVID-19 as it relates to congregate living settings of all types. A few housekeeping notes before we dive in. The first is that today's session is being recorded. We intend to post a link to it and circulate a link to it so that those who are not able to join can view this session later. If you have any concerns about this session being recorded, I would ask that you disconnect now. But again, this session is being recorded. It is possible that your face, or if you raise any questions, will be captured in that. I want to make sure everyone is aware of that. The second is that the information that we are going to discuss today is off the record. If you are a member of the media, please disconnect now. If you are a member of the media and you have questions, please reach out to one of your media contacts, either at the Maine CDC or at the state of Maine government, DHHS, with any of your questions. But today's session is off the record. If you have any questions, if you are a member of the media, please disconnect now. The third housekeeping detail is that, as with everything in the pandemic, the information that we have today may very likely change. And so we'll be discussing a lot of topical scientific issues as well as regulatory and policy changes. However, each of those is subject to change and is current only as of the exact moment of this webinar, which is to say 2 p.m. on December 8th. If you are viewing this webinar anytime after 2 p.m. on December 8th, please recognize that the information here may be out of date. We would urge you to check in with reliable sources, either at Maine CDC or elsewhere, to make sure that the information that you are getting is the most up to date. So with those housekeeping details out of the way, last one on a technical note, which is if I would ask everyone to please mute your line. That will certainly help us go through this as quickly as possible. I also invite folks, if you wish, to save a little bit of bandwidth, to turn your camera off, but do not feel the need to do so. In an era and a time when it's so hard to see different people, sometimes the only chance that I know a lot of us in different communities get to see one another's faces is on Zoom calls. So no, don't feel any pressure to do so. I think the bandwidth is coming through okay, so I'm not sensing any bandwidth concerns. Let's turn now to the agenda for the afternoon. We've got a broad array of folks from Maine DHHS who are excited to discuss with you today. I'll kick things off in a moment by providing a situational update. I'm then going to turn things over to Director Bill Montejo from DLC to talk about where things stand with respect to staffing and the need, the urgency, the imperative to shore up your backup staffing plans in the event of a COVID-19 situation. He'll then turn it back over to me for an update on where things stand with vaccines and vaccination efforts. We'll then turn to Bill Jenkins from Maine CDC for a quick update and discussion on how to calculate PPE needs that you may have, particularly in an outbreak setting. We'll then turn things over to our Director of Testing, Sally Weiss, for some updates on testing options and readiness, and then back over to me for the end for a quick update on where we are with some changes to quarantine guidance. We're going to try to move through that in short order because we want to, as always, leave as much time as possible for your questions. If you've got particular questions on something that a presenter is saying, please put those in the chat. If you've got more general questions, please also put those in the chat, but we'll try to reserve as much time as possible toward the end to take all of your questions. So with that, I'm going to go ahead and kick things off with respect to where we are for situational awareness. Today's unfortunately another sad day in Maine. Just in the last 24 hours, Maine CDC has received the reports of 12 individuals who passed away with COVID-19. Many of those individuals were residents of skilled nursing or other long-term care facilities. Sadly, that trend is one that we've seen continuing and indeed accelerating over recent weeks. Along with that trend, we've also seen, for example, an uptick in the number of new cases. Today alone, 274 new cases. Some of that uptick is a direct function of potentially things like the Thanksgiving holiday. Others of that uptick are just a function of more disease spreading, as well as more cases coming into Maine CDC for review. All of those metrics, unfortunately, are driving what we now see as, for example, an increase in hospitalizations. Right now, just across the state of Maine, there are 171 people who are hospitalized with COVID. 48 of them are in the ICU, and 19 of them are on ventilators. The numbers that we use to track the outbreak and the pandemic on a day-to-day basis reflect this increasing severity. Our positivity rate now stands at 4.7%. It's been getting significantly worse. Although it's plateaued a little bit, we are fearful that it will continue to take a turn for the worse. So the bottom line here is that from an epidemiological perspective, the COVID-19 situation in Maine is one that is deeply concerning. To be sure, Maine is still better positioned relative to other states, but I know that is cold comfort to every single person on this phone call, because even though we may be better positioned than another state somewhere in the upper Midwest, we're still feeling the effects very squarely here. Unfortunately, the epidemiological evidence suggests that the situation will continue to get worse in terms of the new number of cases, numbers of hospitalizations, as well, sadly, as the number of deaths. So that's where we stand. I apologize for that grim update, but as we've always pledged, we want you to hear the truth from us, to hear it from us first, no matter how difficult it may be. I'm going to turn things over to Director Montejo for really one of the most critical things we can talk about today, which is the need to shore up staffing plans. So Bill, over to you, please, sir.
Thank you, Dr. Shah. Earlier this year, back in April 24th to be precise, we put out a staffing guidance document that was really the product of several agencies here within the state working together to give guidance on a progression of staffing and kind of get providers, get all of you to really start thinking of your plans and revising and updating your plans. And while many of you did that, what's really been highlighted in this current crisis that we're in now is it is drastically different than what we experienced back in the spring in March, April, and early May, where there were resources available because of closures in other areas of healthcare and because of the way the vaccine or the way the virus, excuse me, was affecting other states. It has really become very apparent that staffing resources are critical. They certainly, we've heard loud and clear from all of you, they were difficult before this COVID crisis. They are much more challenging now and really at critical levels. And we've revised the staffing guidance, which will be going out today to really revisit that and get some more suggestions and get all of you to really start looking at your staffing plans and really looking and planning for the absolute worst case scenarios. One of the administrators that I spoke with earlier has, looked at his plan and revised it for if he loses 25% of his staff, 50% of his staff, and 75% of his staff, respectively. What does that mean? How does that impact his operations? Where is he going to go? And it's really looking at all options, working with the healthcare coalitions, reaching out and pre-planning with your hospitals, looking at your municipal officials, your local municipal emergency management officers, your municipal government for what assistance and resources are there, what civic groups are available within your facility to really help you. You really need to put pen to paper and start thinking this through, because we agree with many of you that I've talked with have reiterated this. Nobody wants to evacuate or close a facility. And especially during this crisis, the trauma to your residents would be astronomical. But likewise, as we've heard from many of you, it's difficult to obtain staffing assistance and share staffing resources amongst yourselves. It is virtually impossible to get it through state and government resources because there just isn't the resources available either. So we are trying, whenever there's a crisis, we do work with the CDC and with the Office of Aging and Disability and get on calls with all of you and with our staff, with staffing guidance and assistance from the Commissioner's Office to try and help look at options and, have you considered this? What other resources can you look at and utilize? But we just really want to strongly encourage people to really think the worst case and plan it, because you know, inevitably this will happen 9 o'clock on a Friday night or midnight on a Saturday, when there just isn't availability of state resource staff. Other thing that I really wanted to bring to people's attention in the staffing guidance was, in that April document, we required written authorization for the utilization of COVID positive staff who were asymptomatic on a COVID positive dedicated unit. And what we've done is revised that after consultation with the CDC to remove the requirement for written approval. But we are still going to require that there be involvement and approval and discussion with the state, the CDC's EPI staff that are involved. So as many of you have had outbreaks and have had regular calls with a state epidemiologist and are working through the process, the use of COVID positive staff on a COVID dedicated unit is literally a last resort, and only to avoid a crisis situation. It's not a convenience process. So we really want to make sure that we continue to have discussions with providers to make sure that everybody's clear on that. And we will look and ask for you to kind of outline and provide us in a written process with a bulleted, even something as simple as bulleted, about what are the avenues that you've taken, what are the agencies that you've called, the home health agencies. So we're really looking for the kind of the reasonable standard that you have exhausted all other options, and this is really this is the last resort to kind of get us through this crisis on a temporary basis. Not trying to really make a lot of obstacles for you here. We're trying to work with you, but recognizing that the utilization of COVID positive staff who are asymptomatic brings with it risks. And as we're seeing in areas where this is spreading, even despite very due diligence on a lot of your parts as administrators and facility managers, once there's an outbreak in your facility, it spreads. It is very difficult to really monitor your staff and your staff interactions 24/7 to really ensure and remind them to follow the guidance. We've seen it, numerous times where facilities have really good processes and screening steps in place, and there is, one slip in the process in an evening shift on a Saturday night, and lo and behold, that person that was allowed to slip through was positive, and now we have an outbreak. And it was really not anything willful on anybody's part, but it is very hard to monitor and do that due diligence. So you'll be getting the revised guidance from us. Please feel free to reach out to licensing staff or the Office of Aging and Disability Services if you have questions on this, as well as the long-term care ombudsman. And really, as we've kind of mentioned before, is we really encourage everybody to work together to try and come up with even some out-of-the-box solutions to kind of help get through this. I've been one that's been advocating for some type of a way of sharing or mutual aid amongst your staff, and I know it's difficult in a crisis. Every staff person is critical, but I really personally believe that even if half of the nursing homes could give up one staff person in a crisis, that gives a pool that, yes, it's going to be painful for that one facility giving up that one staff person, but is going to be tremendously appreciative of the facility that's facing the crisis. So, I think we do need to look at things and continue to work with things. And we are having regular discussions with the Maine Healthcare Association and really trying to identify what are the logistics and what are the obstacles and how can we help kind of address those to assist with resources. So that's probably where we're at on the staffing, and I know there will be questions and we will try to get to those. Thank you.
Great. Thanks a lot, Director Montejo. I think what Bill just walked through is really the most important thing we can leave you with today, which is if there are, if you have been, today is the day to identify the very last and most minor set of gaps in your contingency staffing plan, because Once you start seeing cases and then reach outbreak status, it can quickly become too late. So as Bill mentioned, today is the day to do that, whether it's models that you thought were inconceivable, like 75% of your staff being out, which earlier in the summer may have seemed completely outlandish. Today, that is sadly a reality. So if you do nothing else after this call, please shore up those staffing plans. Again, we'll take questions about that for sure. I'm going to go change gears now and provide a very brief recap on where we stand with respect to vaccines and vaccination. The first thing is that Maine CDC, the state of Maine, has officially activated the partnership model that has been developed by the US CDC, working in concert with commercial pharmacies. We have had wonderful uptake and sign up from many of you, maybe all of you indeed, to participate in that commercial pharmacy partnership to vaccinate your staff and your residents. We have activated that system. The system proceeds in two parts. Part A focuses on skilled nursing facilities. Part B will focus on assisted living and intermediate care facilities. Part A is where the focus will be for the next several weeks. We have done the part that we were asked to do at the Maine CDC, which is allocate the requisite number of doses so that when that partnership is ready to go, when Walgreens and CVS start reaching out to your facilities to schedule those clinics, we will have at least the first dose available, and then in subsequent weeks, the secondary dose is available. What I'd like you to do now is the following. Vaccines, and especially vaccination for COVID-19, will be a brand new thing. It will be something where for at least two of the vaccines, they will use a different modality. There will be data that we would all love to have many years of, but indeed may only have a couple of months of. Certainly, as a result of that, there are going to be questions. I ask everyone today to start talking about COVID vaccination with your staff, with your residents, and with family members. In the not too distant future, the US CDC will be releasing a COVID-19 vaccine toolkit for nursing facilities and congregate living settings, but that may be another week or two. And vaccine may start to be showing up at your door in another week or two, maybe 3 or 4, no one knows for sure. But my point is, I ask all of you to start having discussions with your staff, with your residents and their family members today. There are going to be difficult questions around things like, what does informed consent mean? How do you need to make sure that family members are okay with their loved ones, some of whom, for example, may suffer from dementia? Making sure family members are okay with their loved ones being vaccinated. Do you know what fraction of your own healthcare force at your facilities wishes to be vaccinated? Now is the time to start having those questions. One of the ways that we can drop this ball is for vaccines to show up and for vaccine clinic folks to show up from Walgreens and CVS, but not have anyone to vaccinate. So please today start having those conversations. Once the toolkit is officially released by CDC, US CDC, we'll distribute that to you, but you don't need to wait until then. Please start having those conversations today. And again, we'll take more questions about that. But just in order to plow through all the updates that we've got, I'd like to turn things next over to Bill Jenkins, the head of emergency preparedness at Maine CDC, to have a discussion or an update on where things stand with calculating your PPE needs, particularly in an outbreak setting. Bill, over to you.
Yeah, thank you, Director Shah, and good afternoon, everybody. Just wanted to provide a couple of updates and some observations around PPE. And the first is, if you folks haven't been able to, now is the time to kind of start thinking about your PPE calculations. When you're in the middle of an emergency and unable to find staff, that's not really the time to start thinking about what will I need for PPE. So there's a number of different PPE calculators out there. I did throw a couple in the chat that I found to be fairly useful, but again, there are a lot of different ways to do it. But I guess the short of it is that use some of these tools and think about it in terms of how many patient interactions would a specific person have over the course of a shift, and that's going to be very different from provider to provider. So somebody who may work in the environmental services may not have patient direct interaction, whereas somebody who's providing direct care, they would be using more PPE. So the reason that we're mentioning this is because, as we see the PPE resource requests that are submitted by you folks through your county EMAs come to the Maine CDC. And I just wanted to talk a little bit about what that looks like behind the scenes. So when we have that, there's a number of questions we do ask you folks to answer. And those are things like, do you have a respiratory protection plan? Have you been fit tested within the last 12 months? And a couple other qualifying statements. But what we've seen happening is for instance, there are some small facilities that, really haven't thought about what they may need for PPE over the course of this COVID outbreak. And, when times are dire and folks are stressed out and people are very, very sick, your default is to just throw a number out there. But I just wanted to help folks kind of, realize that really kind of gums up the work on two fronts. You have the county EMA directors who are now kind of in a position where they're not familiar with patient census, how many PPE that you're asking for. So that gets bumped over to us. And from our aspect, we are going online and looking up as best as we can your patient census, what your outbreak status is, so that we can actually determine what we feel is an appropriate amount of PPE. And the reason we're doing this is because, just as an example, this isn't an actual facility, but say you have 20 staff and 50 patients. We're getting outlandish requests for PPE. I mean, in the order of, we need 50,000 gowns, 20,000 gloves, and that is not going to work. I mean, our PPE cache isn't able to handle that volume. So what ends up happening is that there's a lot of work on our back end to try to, again, go on and figure out, okay, what is your actual patient census? What is your staff? What's the level of staff? And also trying to figure out what would be something more reasonable. So that is really kind of the onus of today's call, is to just say, like the staffing requirements, please give some consideration to your PPE calculating rates. And again, I did throw a couple of resources in there that'll help you through that process. And it will take a little bit of time. It goes by provider level, number of patient interactions, percentage of time that you may be required to be in PPE while providing direct care support. So like Bill had mentioned earlier, the time to do that is not when you guys are going through a crisis. And also just wanted to let folks know that, the gloves and a couple other things that we are seeing really good. So to date, we've received all of the nitrile exam gloves that we've been able to procure. And what we have is what we have. And we've actually seen the raw materials for the manufacturer of nitrile pretty much non-existent. So what this means is that, what we've been able to kind of procure since the beginning of this is pretty much what we're going to have to last us for the foreseeable future. So again, we just try to make it look at it in terms of, when you're asking for PPE, do your due diligence, make sure the numbers are reasonable. If they're unreasonable, or if we feel it's way out in left field for the number of patients and staff that you're looking after, we will kind of make those adjustments downward to something that's more palpable. So for instance, surgical gowns, there are different things that are just kind of coming up on the national global market that are non-existent. Another one is N95s. We actually have a fairly small supply of N95s in our cache as compared to some of our other items. For instance, we have a million pairs of gloves. We have 590,000 face shields. But face shields are reusable. But again, what we have now is kind of what we have. So the more that we can do to conserve on your end, again, we're not saying don't skimp. If you need something, just let us know. Hey, this number may look high, but here's our reasoning. And again, you don't have to get into a thesis on the request form, but it's one of those things where you may get a call back from us just to say, is that number right? That looks a little bit high. If you're a repeat customer of ours, we traditionally have been tracking what your requests are. So if we see an outlier, for instance, where you've normally been, let's say, requesting 200 N95s, and all of a sudden we see 5,000, rest assured we're going to follow up with you folks just to see if that was a typo or if that's actually a true need. So just a little bit of, just some things to consider. And again, it's think about, we try to say, think about these things before you need them, realizing it's hard. You folks are doing a very difficult job, even under blue sky times, let alone into a global pandemic. So I guess if I could leave you with the best advice is, consider using some of the PPE calculators. If the two that I provided in the chat really don't work for you, you can literally just type in PPE calculator and there'll be more options there than you probably can go through. Those were just the two that I've seen in use and I thought were pretty comprehensive. And there's everything from that all the way down to it's literally just how many N95s you need and how many days you work, right down to a very plain Jane sort of spreadsheet. But the ones I provided actually do extrapolate out provider level, percentage of time, number of patient interactions. So it's a little bit more intuitive than just, I have 5 staff, they need 5 N95s a day, so we need 25 N95s. And also just wanted to say too that we've pretty much exhausted our ability to provide fit testing. So, what we're seeing now is that, with the supply shortage of N95s and also the increased demand to do fit testing, we're probably going to have to go back to some of our prior guidance where we recommend a face shield and a surgical as providing adequate. So again, as the N95, pretty much dries up, not just in Maine, but across the globe, I think we're going to be looking at those types of things. So if you don't get it at what you were expecting to get, just reach out to us. We are humans, we do make mistakes, and sometimes we have typos and fat finger syndrome on our end too when we're typing in your pick list. So just wanted to touch base on a couple of those important points, and I'll turn it over to Director.
Thanks a lot, Bill. Again, we'll take questions on all of those, on all of these updates in just a bit. Another interrelated topic with along with PPE is where we are with respect to testing. And so I'm going to turn things over to Sally Weiss, who's the Director of Testing with us, to provide updates there. Sally, I'll turn it over to you.
Great, thank you. Good afternoon, everybody. I am just going to review a couple of things around universal testing, which may be triggered by a positive case in your facility or an outbreak status, which is 3 or more cases in your facility. I just want to remind people what that process looks like and steps that every facility can take now to be prepared for if and when that occurs. I think the biggest challenge is when a facility does have a positive case and they're starting from the ground in terms of what their next steps are. And when they're trying to do everything else, it just adds to the stress. So I'm just hoping I can provide some information to you on those pieces. So first and foremost, any facility that has a positive case or is deemed an outbreak can use the state lab for their samples. In order to use the state lab, you do need to register your facility with us. We need to actually enter your facility information on our back end side. And then we also need to have you enroll in the lab portal. I will post the lab portal information here. Oh, nope. Did that go work? Yes, it did. And so one of those pieces is going ahead and registering your facility and going ahead and getting registered in the lab portal and familiarizing yourself with how you submit information for the samples you're collecting and submitting to the state lab. I'll also just note that any facility is welcome to use the reference lab as well. By no means are you forced to use the state lab, but it is an option for you. Once you register with the portal, we require or request that all facilities use something called a batch upload, which basically means you would put all the resident information as well as staff information into what looks like an Excel file. And when you complete all that information, you would upload it into the lab portal and it creates the lab requisition forms. These forms are then printed with all the information you entered in the Excel file for each individual that you are collecting a sample from. The nice thing about this is that previously we would have folks fill out a requisition lab form by hand, and sometimes it was hard to read. Sometimes you couldn't quite match up the labeling on the sample with the lab rec form. So this allows you to do that. One of the benefits of the lab portal and the Excel file that you download from the lab portal is that you can go ahead today and preload your staff and resident information and have 2 files saved and ready to go. Of course, at the time of testing, you will want to verify that the individuals on that list are the ones you're collecting samples from, but it will save you a lot of time and will allow you to quickly get going when you realize you need to do universal testing or you're in an outbreak and your case investigator tells you you need to test everybody in the next 3 days. So I would strongly recommend that you take those steps to do that and just getting yourself organized in that way. The other thing I would say is have your supplies on hand. If you haven't already, I would consider requesting enough supplies to test your residents and staff for 1 round of testing. Again, if you go ahead and request it through your EMA today, it can take 5 to 7 business days before you will receive the swabs and the viral transport media. And again, if you need to do this within just a 48 to 72-hour period, that's not enough time. So again, go ahead and request enough supplies to get you through 1 round of testing, as well as what Bill noted, any PPE you may need. Lastly, you will want to think through how you're going to get the samples to the state lab. A lot of facilities don't realize that they have to courier the samples to the state lab. And for some facilities that are further away, that can be a challenge. We have had facilities partner with other local organizations. So if you have a nearby hospital that is sending samples daily to the state lab, you can partner with them, or you can partner with another organization that may be sending samples. Alternatively, there are some organizations that do just courier samples, and you can obviously contract with them and they will pick up the samples and bring them to the state lab. Facilities also sometimes will send an employee down to the state lab to drop the samples. All of those are options. The other thing I would recommend is, if your facility requires it, is having a consent on file for testing, both potentially staff and or residents. Again, every facility is different, but I would ask yourself whether this is something that would be needed and going ahead and having that ready to go. I think that's about it. What I can do is I can send the information to Paul after this meeting, and I can send the user guide for the lab portal, as well as an FAQ for submitting samples to HEDL. And in that FAQ, there's lots of good information about shipping and how you organize your samples and how you label your samples. So it's a great resource. I also just want to note that we still believe that, or we still are recommending PCR testing for universal testing, especially for asymptomatic individuals. I've had some facilities ask around. We just recently acquired the Binax Now, which is an antigen test card. We are recommending that solely for using in critical infrastructure staff, which would be healthcare workers in your facility, if you know that they've been exposed to a confirmed positive. So kind of going back to the beginning of this meeting where Dr. Shah and Director Montejo were speaking to staffing, you can use the antigen cards in those instances as a way of maintaining staffing levels, meaning that you would test the individual serially every day prior to their shift. And if they are negative, they would proceed with their shift wearing appropriate PPE. So I just want to note that that is the use case for those specific tests. They are not to be used for universal screening of residents and staff. I think that covered it. And certainly if there's any questions, yes, anterior nasal swab is perfectly acceptable, as well as mid-turbinate. I've also had facilities ask me whether staff can self-swab. Yes, they can self-swab. They should be supervised by somebody who at least understands what a good collection method is, but absolutely they can self-swab. And lastly, the antigen tests. We just learned actually yesterday that we believe we're going to be getting a very substantial shipment of the Binax Now antigen tests next week. I will say that the distribution from the federal government has been significantly lower than what we had anticipated. And so our current inventory is far, far behind where we thought we would be, which has limited our ability to approve and distribute the tests to those facilities needing them. I'm well aware of all the facilities that need them, and it's our priority to approve and distribute the tests as soon as we receive them. I'm hoping I'll be able to do so as early as next week.
Great. All right. Thank you, Sally. And let me just turn really, really quickly to Director Saucier. Paul, is there anything really top of mind for you that that you want to offer?
Well, as you've already noted, Dr. Shah, the staffing is the primary critical issue that we're seeing every day now. So just to reinforce that, you know, you should review and re-review and re-review what your plans are and assume the worst, because we are definitely seeing extremely tight staffing situations.
Great. Okay, so let's all take a break. Let's acknowledge that we have just thrown 37 minutes of really dense information at you, ranging from staffing to testing to PPE to vaccines. And we've given you a to-do list that would take any normal person a couple of weeks to get through, and I'm asking you to do it before dinner time. So let's just acknowledge that we've thrown a lot at you. Let's all take a break, clear your mind for a second, and I'm going to scan through the questions here to pick out a couple of themes, starting from the top. But again, please put your questions in the chat. We've gotten a fair number of them. Sadly, we won't be able to get to all of them, but I will try to look for some themes, which I've been trying to do as things have gone in. Before we go to that, though, I'll just offer one note. We've said for months that these are unprecedented times, and just in the past 2 weeks, what was previously unthinkable has become a reality of hundreds of new cases per day. Sadly, multiple fatalities being reported to us, and many of those cases, as well as those deaths, are connected with and coming from your facilities. And I want to take a second to acknowledge the psychological stress and trauma that has on all of you, as well as to thank you for continuing to stick with us. We've been on the phone with many of you in different capacities, outbreaks and otherwise, over the last now 11 months. We've been working on COVID-19 matters. And we know that you are all doing as much as you can, and that the toll of the pandemic is being visited upon you, as well as your residents, as well as your own families. So I want to take a second to acknowledge that, and thank you for sticking with us. So with that, it seems like there are a lot of questions around vaccines and vaccination. Oh, darn it, I forgot. There was one last thing, which is the change to the quarantine, which was on the agenda that I was supposed to do, but I jumped the gun on. So let me just discuss that really, really quickly. About a week ago, the US CDC announced, after reviewing a lot of epidemiological data from the US as well as some other countries, they released a scientific analysis of what could be a potentially lower threshold of a quarantine period. As all of you are aware, right now, for someone who's exposed to COVID-19, the standard quarantine period recommendation has been 14 days. They released a scientific brief looking at the potential impact of lowering the quarantine period. As it relates to you and your facilities, this could mean the difference of having an exposed healthcare worker out for a shorter period of time. Now, again, we've already made allowances to allow exposed healthcare workers to come in. And as a belt and suspenders approach, ideally to have them tested on a frequent basis with Binax Now. But those are suboptimal situations. So CDC wanted to characterize the risk of allowing folks to end their quarantine period after 10 days, not 14 days. We at the CDC analyzed and took a look at those data, and we feel at this time that that is appropriate. So last Friday, we changed our quarantine guidance from 14 days to 10 days. We still recommend that people who have been exposed get a test, but it doesn't shorten the quarantine period. It's still 10 days. We also recognize, though, that different facilities may have, we believe that that guidance is appropriate for employees of long-term care facilities, as well as folks in the general public alike. But we also recognize that you and your facility may opt to make a different decision with respect to the quarantine decision. You are always free to go or stick with the 14-day period. If you feel like the 10-day period is one that's acceptable to you, we feel like that is a good baseline for the state of Maine, but certainly you'll get no guff from us if you want to be even more protective. So that was the last thing I was going to mention. Now I'm going to try to pick up some questions. It appears like there are a fair number of questions around the vaccines. One that's come up a lot is around the vaccine information statement, the VIS. That will not be officially released until or unless FDA authorizes the Pfizer and later the Moderna vaccine. So the VIS will accompany the authorization. And we know how critical having that VIS is for you for the related questions around informed consent. So as soon as that VIS is available, we'll make an effort to circulate it. I suspect you and your colleagues will circulate it amongst each other long before we get it to you. But as of right now, there is no VIS only because that is a part of the emergency authorization process. Okay, let me just try to pick up a couple of questions here and look for some themes. Another theme that has come up, again, a lot of questions around vaccination. So another theme that has come up is processes around vaccination. For those of you, which I believe is almost everyone, who are participating in the vaccine partnership, the process for vaccination will be over 3 vaccine clinics. There will need to be some staggering of which among your staff get vaccinated on which days. In the toolkit that I referenced earlier, there will be guidance around this. The reason being is that one of the side effects based on FDA's analysis that we all know of from any vaccine is signs and symptoms of being a little sick, a little bit of headache, a little bit of muscle ache. In a normal world, those would be signs and symptoms suggestive of COVID, which would necessitate the staff member being out of work. But in the setting of having just been vaccinated 24 hours ago, well, we can't have half or all of your staff be out of work the day after they get vaccinated just because of a known expected side effect. So CDC is analyzing that, but the bottom line is going to be to stagger your staff as they go through the vaccine process so that you don't have all of them out. Let me try to pick up a couple of other questions. In terms of consent forms, Director Saucier addressed that as well, but we understand that the toolkit that will be forthcoming will have a draft consent form. Again, it will not be the official consent form. You are free to modify it in consultation with your executives or your board as you see fit. It will merely be a template that you can adapt for your purposes. We understand that Walgreens and CVS, as Director Saucier mentioned, we've at least seen the consent form from Walgreens and we found it to be sufficient. We're waiting to see the one from CVS as well. Okay, let me try to pick up some non-vaccine related questions here. And if you'd like to voice a question, feel free to unmute and chime on in.
Can you talk a little bit about visitation for residents as we head into winter?
Sure, Director Montejo, I think between you and Director Saucier, that'd be perfect.
So as we referenced before, CMS put out guidance for the nursing and ICF facilities that is also similar guidance that we are applying to the assisted housing providers, which is, and it's referenced in QSO 20-39, which is the memorandum about visitation, and gives guidelines for screening process and when visitation should be allowed. And I did see earlier there was a question about, is visitation required if there's a COVID positive visitor? And in that guidance, it does also allow for what you would restrict, and it's in the required visitation, but essentially a facility that's restricting visitation has to do so. Facilities may not restrict visitation without a reasonable clinical or safety cause consistent with, and it gives a reference number for regulation. For example, if a facility has no COVID-19 cases in the last 14 days, its positivity rate is low, the nursing home must facilitate in-person visitation. However, if you're in the middle of an outbreak and you have a COVID positive visitor, it's really the medical director or the physician for that resident that has to determine, is this visitation really required as a compassionate care visit for this resident? It's patient-centered, not family-centered, but patient-centered. And there is a provision that allows you to restrict that if it's not really required and if the risk of the visit is greater than the perceived benefit. So, I think for very detailed questions, specific questions, you can reach out to us and we'll have one of the surveyors get back to you.
What I would add to that is that we have done, we got lots and lots of questions on this. So we do have an FAQ out on the ODE's website, and I'll share the link in the chat in just a second, that it helps people work through the different scenarios.
Can I just ask a very quick question on that? Bill and Paul, Todd Goodwin here. I know we don't get into the details here, but would you consider a county being in the high transmission rate as a condition, a clinically significant condition that might argue against facilitating a community visit, Thanksgiving, Christmas, something like that, particularly if we as a provider have suspicions on the veracity of the claims of compliance made by members of the planning team?
So go ahead, Bill.
In and of itself, I would say no. I mean, they're very, it really is a case by case of resident-centered decision. So it really has to boil down to what is the resident's need and the resident's best interest when determining that. And this is also addressed in that memorandum, Todd.
Yeah, I would just echo that. We understand the challenges, and right now 15 out of 16 counties are in that high transmission category. We've provided, as you know, Todd, the risk assessment tools that you can use to kind of work through that. Certainly when transmission moves to high, as it is in most counties now, visitation is more restricted, but it's still an individualized process of decision making.
I have a couple of questions, if that's okay.
Yes, go ahead.
I have 3 questions that I guess our agency is just kind of really eager to understand and support. I was recently in a meeting a few weeks ago, and so when we ordered the face masks, in that meeting it was identified that cloth is really not that great and that they should be surgical masks. And I would just like to clarify as well that I work in adult group homes for adults with intellectual and developmental disabilities. And so when we're ordering the face masks, we're ordering them on the understanding that the surgical face masks are only good for 2 days, and that the cloth ones are not really that great. And so granted, I'm grateful for everything that we've received, but we've mostly gotten the cloth masks, not surgical. Aside from that, there is the antigen test machine. And I was my understanding that if somebody had come into contact with somebody with COVID, that if we gave that test to staff who had maybe worked the shift with them, and it came back and it's 15 minutes, to my understanding, negative, they could go back onto shift wearing their PPEs. And I'm not sure if as a residential facility versus like a nursing home or something like that, if we are qualified to administer those tests, and if we are, where we would get them. And then our areas are considered relatively high risk. So we're trying to really restrict visitors or visiting people because some of our areas are really in the red zone. And then we're fighting a lot of clients' rights battles and attorneys and what they can and cannot do, which is essentially really putting the agency at risk. So we're kind of really struggling on how we manage all of those areas.
Sure thing. Thanks for posing those. As to the first one, just to make sure we get you the answer straight from the expert, Carrie Rice, who's a member of Maine CDC's Medical Epidemiology and Healthcare Associated Infection team, is on. Carrie, could you tackle the first question about the best kind of masks for that facility?
Sure. So just to get a little bit of information about what we call face masks. So you probably heard different terminology: face mask, face covering, surgical mask, medical mask, procedure mask. So when we look at masks and we look specific to healthcare, there are two kinds of masks that are recommended for healthcare. They're what we call a medical mask, and underneath that's a procedure mask or a surgical mask. When you look at these, they're within those masks for healthcare, there are also what you call different levels, and these different levels are related to barrier protection. Your level 1 would be your lowest procedure mask, and then it goes up to level 3 surgical mask. So when you're looking at healthcare and you're looking for what we are truly considering as personal protective equipment, you would be looking at a medical grade, either procedure or surgical mask. And we know with challenges with what you are able to find, then one of those would be appropriate. When you're looking at, are you using and you're really utilizing personal protective equipment, a cloth face covering would not be considered PPE. It is considered appropriate for use when you're looking at your general public. I know that there's been some settings and for some facilities, if they're not truly using it for the PPE necessary, like you don't have any COVID positive cases, you're not in an outbreak status, I believe there's been some leniency with cloth face coverings. But if you're truly looking to have that level of what we call PPE, personal protective equipment, you would want a medical grade mask, which is either a procedure or a surgical mask.
And then you had a separate question about the antigen testing. So the bottom line there, the central inquiry as to whether any particular facility can utilize the antigen test is whether they've got the requisite CLIA waiver. Getting a CLIA waiver is not an arduous process. It's a 2-page form and I believe $180. And we are attempting to turn those around within a couple of days. As quickly as possible. So it is not an arduous process. We urge folks to go through the steps that are needed to get that CLIA waiver, which then empowers you or enables you to receive the Binax Now test. There still needs to be a qualified healthcare provider involved in the administration of that test, but it need not be. It can be virtually any healthcare provider. So we urge everyone to take a look at that. I believe Sally has put in the chat the form from which you can take a look at the requirements, our guidance document, and where you can sign up. As Sally mentioned, we are supply constrained on those tests right now because of production difficulties at the manufacturer, but we hope to see more coming in the door soon. Other questions?
Dr. Shah, this is Ray Nagel. I'm from Independence Association, and I would like to get a clarification from the doctor that was just referencing masks a few minutes ago. Mm-hmm. So the guidelines that we've received from DHHS refer to source control and PPE. And as I understand, source control is basically controlling the source that the virus emanates from, your nose and mouth. And we have been told, I work in I'm the executive director of group homes that are not medically based, but work with adults that have intellectual disabilities. And we've been given guidance that if there's nobody in the home that is positive with COVID, that they can wear source control as masks. which is a significantly cheaper alternative. And what I'm just heard a few seconds ago kind of creates a little bit of confusion in our field. And I was hoping that we could flush this one out a little bit better.
Yep. So it depends on what you're using them for. So if you're in a nursing home or you're in like a hospital, then really it's generally recommended that you use personal protective equipment and you use what I described as the different versions of the face mask. In sort of your settings, when you're doing their source control, you don't have any active cases, you don't have sick individuals. There has been people using the cloth face coverings. What I want to denote is that a cloth face covering is not considered what we call personal protective equipment. And so if you needed that level of personal protective equipment when dealing with positive individuals, outbreak status, then you would want to look at using that type of mask.
Yeah, I understand. So source control is okay. And I refer to cloth masks as source control. That's how it's been defined by DHHS. And so until there is a COVID positive case, we're going to continue to use source control. And then if there's something that's positive, we will go to the gold standard.
And just to reference, if your source control will be the wearing of a face covering, no matter what type of face covering it is, to protect others from yourself if you might be sick. So we use that terminology a little bit broad, and I think where it does get confusing is if you're, depending on which population you're looking at and what you're using it for, there's all this different terminology is out there. So yes, it can be very confusing. The other thing that I just wanted to clarify, and just looking at some of the chat in there, is in standard practice, not in the middle of a pandemic, every day before this all occurred, when we look at our PPE, PPE is intended to be discarded after use by patient, by situation. Because of the pandemic and because of the challenges that we have with supply, most places, and many places across the country, have had to implement what we call extended use practices. And so if you are wearing a individual face mask for an extended period of time, an N95, meaning you're not discarding it after use, that is what we call extended use. So I just want to clarify, there's not a magic number with a mask. The other thing that you want to think about is the structural integrity of the mask as you're doing it. So if you have a mask and it is quite saturated just with your own natural secretions, it's not going to be effective as one that is not. So if you are practicing what we call extended use practices, I'll put the link into the chat here. There are specific guidelines that the CDC has given to make sure that you're doing that appropriately. It is an area that we have identified with multiple facilities where they're doing these practices, but they might not be aware that there are guidelines that go along with that. One, to make sure that you're protecting your patients, your residents, and two, you're also protecting the wearer. So I will send the link to some of those websites just for reference.
Great. I think we've got time for one last question. I know that there have been just a multitude in the chat, but I think we've got time for one last one.
I'll throw one in there if you don't mind.
Please go ahead.
With the CVS call yesterday, it sounded like the assisted living communities, along with the nursing home communities, would be the first ones to be served, both the residents and the employees. But I think I hear from you that it's going to be the nursing homes first, and then some time period after that, then it will be the assisted livings. Does the CVS have the authority to make that a determination on that, or is that governed by the CDC? And if there is a time spread, what do you think that time spread will be between it coming out for nursing homes and coming out for assisted livings?
Great, thank you for that question. The order of operations that has been recommended by the US CDC is that Part A will be focused on skilled nursing facilities, Part B being focused on assisted living and intermediate care. It really is more US CDC that is organizing it, although the state does sort of say when to start activating each phase. Now the time period, I don't have a great sense. Going by the numbers, the reason I don't have a great sense is that I don't have a good sense of what the vaccinating capacity and throughput of the various respective pharmacies will be. I anticipate that the difference will be hopefully around the order of weeks, but I can't put that on the record. I wish you could hold me to that, but it really will depend on how efficiently and quickly Walgreens and CVS are able to start vaccinating folks at their various clinics. I'm hoping that it can be as short as possible, but to be candid, it may not be. Once we have a better sense after the first couple of days of what their throughput is, we'll be able to move ahead.
Okay, thank you.
You bet. And everyone, I unfortunately have to draw us to a close this afternoon, but I do want to thank everyone for taking some time to hear the latest. We recognize we threw a lot of information at you. We will be sharing this link, posting this link on our website, et cetera, for later viewing or for you to go back and take a look at to reference any of the reports that we made. We are going to continue with these calls on a regular cadence so you can hear the latest from us, and we will endeavor to try to build in as much time as possible for more questions. Apologize we couldn't get to more of them today, but there were so many updates that we wanted to share with everybody. But we'll send around a link soon. In the meantime, I appreciate everyone's time this afternoon. Have a good afternoon. Take care, everyone.
Thank you. You as well.